all, I would like to welcome you for attending this webinar. As you know, this webinar is one of the activities that DG Santé is doing to support all the clinicians on the front line, on their fight against COVID, and also to learn from your experience. In this case, this concrete webinar, it's very important for us, for the Commission, and I would say for all the involved people, because we are trying to get all your information, your knowledge on what to do and what we should develop in to prepare a possible second wave of the COVID-19 pandemic. So I will go directly to the logistical issues now. We will ask you to participate as much as possible. You will not have the capacity to talk because it will be very difficult with this type of webinars, but we encourage you to participate in written as much as you can. We will pose some questions to you. We will appreciate if you can put your opinions, your answer, or your questions either in the chat or in the question and answer functionality that you will see in your screen. And just to inform you that in any case, the webinar will be recorded as well. So, and the presentation will be made available in the webpage of DG Santé. Today's agenda, it's quite impressive, I would say, because we will have the participation and we'll welcome you in a few minutes of our Director General, Anne Boucher, who is personally very involved with this issue. And it's really looking for your feedback and for your inputs on the lesson learned and what do you think could be done on this. And then after that, we will have the Deputy Director General of DG Santé, Martin Seykel, who will give a short overview of what's the lesson learned and what the Commission is trying to do for the preparation of the possible second wave. And after that, we will have a point that will bring together the opinion of the Intensive Care Specialist Society, the European Intensive Care Management Society, represented by Maurizio Cecconi and Joseph Kesioglu, who are the President-elect and the current President of the European Society of Intensive Care Medicine, with the also participation of Andrew Rees, or Director of Health System, Medical Products and Innovation. After that, we will have a session of question and answers, and it's there where we really encourage you to participate, to be active as much as possible. So now I will pass the floor to our Director General, Anne Boucher, to welcome you. Thank you very much.
Dear conference participants, this is Yara Sonnenschein, the personal assistant to Anne. I'm sorry to say that Anne is not back yet. She will arrive very shortly. I just ask you for a couple of minutes of more patience, please. Thank you.
Okay, in that case, I will this opportunity to explain you a bit what we would like you to do, if possible. We will appreciate your collaboration in that. Is that at the end of this meeting and after the debate, we want to have your views in a structured way. For that, we have prepared a survey. It's called EU Survey. It's short, and we will invite you to fill this survey that will pop up in your screens, in your browsers after leaving this webinar. In any case, we will send also the link to this survey to all of you, that you can do that later on if you do not have time at this moment. And with all your contribution, we will try to identify the main elements that you as clinicians are identifying as an issue to be considered. We will put that together with the inputs coming from other important stakeholders, of course, like the hospital managers, etc. So, with all this information, we will try to put a common approach to this key issue for the next months. So, I will pass now the floor to Anne Boucher, our Director General, who is already with us.
Mm-hmm. Thanks, Enrique, and good afternoon, everybody. And really, I'm extremely grateful that we have this opportunity to have a direct line with you for a moment. I think you're probably the most busy people of the EU right now, and so I'm even more grateful for your time. I mean, your work has been critical to overcome to contain the outbreak, and in very difficult circumstances and under a lot of pressure, you have gained experience in handling COVID, and this is extremely valuable to us. I mean, I think if we go back a couple of weeks back, I mean, at the start of the outbreak, it was extremely chaotic at the European level, and we saw as the outbreak was developing that there was a demand for more and more coordination. And so now, as Enrique has explained, what we would like is to make sure that we can support the work of in an efficient way, in a targeted way, with a good understanding of the needs on the ground. We can support the preparation for the second wave. So for us, it's a very good opportunity to get your feedback and to get a better understanding of what you see as the risk, the needs, and the difficulties as we move towards the autumn and we have more and more deconfinement. So I'm really extremely eager to get your feedback on all these issues. I mean, we're several of us today to be able to have this interaction. So I leave the floor back to my colleagues. Thanks a lot.
Thank you very much, Anne. I will pass the floor now to Martin Sequer, our Deputy Director General, who will give you the overview and the lesson learned from the Commission perspective on the COVID pandemic.
Thank you, Enrique, and good afternoon to everyone. I hope you can hear me well because I had some problems with my audio connection a few minutes ago, but I hope
we can hear you well.
Perfect, thank you. So indeed, this is a very important time to have this discussion because the first wave, the so-called first wave, is now largely behind us, and let's just remind ourselves of the terrible toll this has taken. As of 10 June, we are approaching 1.5 million cases in the EU, EEA countries, and the UK, not to mention, of course, what's happening in the rest of the world, and just under 170,000 deaths. So as we look to being better prepared for a possible eventual second wave, this is indeed a very important discussion to have. We can certainly do that now because the number of new cases at the moment is low, and we are progressively in many countries lifting a number of the containment measures that have been affecting many fields of life. But of course, the first message I think we have to continue to emphasize is that it's not over, definitely not, and we need to continue to maintain the essential infection prevention and control measures, so the physical distancing, the hand hygiene, precautions, etc. But of course, very important now to use this period, and we don't know how long this, let's say, quieter period might be, to be better prepared for a possible second wave or subsequent waves, and indeed, in the longer term, also to be better prepared also for future health threats, because we are learning lessons from this crisis that we should not forget even when the crisis is definitively over. So just some key points for reflection. We are already reflecting within the Commission, first of all, the crisis, like any crisis, uncovers weak points in the system. And we are looking also at the roles that the various actors in the European system have, the various responsibilities. So we are looking at the legal basis. One thing which became clear, particularly in the early stages of the crisis, was that it took some time for the Union to act and trigger a number of preparedness and response measures. And this obviously was to some extent attributable to the fact we were dealing with a relatively unknown quantity, a new threat, but also because our systems may not have been designed in the best possible way. So that's something we are looking at to see from a organizational and legal perspective. Just to give an example, at the moment, the obligations of member states are limited to reporting on key capacities for preparedness and response every 3 years. So they do that every 3 years. There is a process. They send reports. There are no targets. There are no specific or measurable standards in place. So obviously, a lot of information about preparedness plans, capacities, gaps is limited. And that is something we will need certainly to address in the very near future. We also should look at how we can improve and strengthen our approach towards surveillance. With hindsight, and everybody is wiser after the fact, there were certain signals maybe early in the crisis, maybe even while the disease was still originating in China and the first cases in Europe, where we could possibly see opportunities to be ahead of things in the future. So when it comes to the use of electronic health records, the systematic application of big data analytics, artificial intelligence, how to really bring together a multitude of different data sources that could give us a very precious early indication. And this is something very important also for the second wave. The key to ensuring that we can successfully handle a possible potential second wave is to be as ahead of the curve as possible. And therefore, we need to be not only reacting to cases when they occur, but also trying to pick up the first indications that the curve might be in an upward trend. Then when we saw in the early stages of the outbreak, there were a number of issues relating, for example, as well to the necessary response. So it was made very clear, for example, that the stockpiling capacities of member states were clearly inadequate. This led, of course, to problems when we asked countries to show solidarity, because no countries had sufficient stocks that they could certainly share with other countries. And this is something, again, which is, I think, a valuable lesson also for the future, not just for the second wave. Certainly, we need to be prepared also for a second wave. Let's just remember, for example, it takes time as well for industry to produce the exceptional amount of certain critical supplies that will need to be in place if and when there is a second wave. Therefore, we also need to examine the feasibility of large-scale centralized procurement of vital supplies, such as personal protective equipment, very important, but also other essential public health goods, such as medicines and medical equipment. And depending on the items in question, some of these are more difficult than others to produce in large numbers at short notice. So the Commission is currently working closely with member states to establish strategic stockpiling for medical devices, for personal protective equipment, also for therapies where appropriate. And again, this is work which will need to be done over the next few weeks and months, certainly over the summer. And we should be very well prepared, because obviously we will definitely in autumn and winter be facing the usual seasonal flu peak. That might coincide with a second wave of COVID, and of course the accumulated pressure caused by two peaks happening at the same time would be quite substantial. So we need to be prepared for that. This crisis has also underlined the importance of a number of other issues. For example, there were major problems also caused by the fact that we have become, as a region, very reliant on other parts of the world for things like medicines, even essential medicines, or raw materials to produce medicines. And of course, when you're dealing with a pandemic, which is global by definition, everybody is in the same boat, and therefore there were enormous disruptions to supply, because countries were, of course, trying to secure their own supplies first, but also there was also a massive disruption in industrial production in many parts of the world, and of course, especially in countries which are very major players in the content and other goods. So we need to look at this, and we need to see how we can improve and have a greater security of supply when it comes to medicines, essential medicines, medical devices, etc. We also had, I would say, an industrial problem, because the demand and supply for medicines, medical devices is normally very well balanced, very finely balanced, and actually demand, as was the case in the past months and weeks. Industry finds it difficult to ramp up the supply, and certainly at short notice this is sometimes impossible. And of course, this is exacerbated if you have weaknesses in the supply chain, dependence on third countries, whether it's for raw materials, parts, and components. A few words also on, the kind of what we call exit from this, because we don't know if and when and how, there will be a second wave. If there will be a second wave or subsequent waves, how big will they be? Will they be comparable, smaller or larger than the first one? But we know the only definitive way out of this is if there will be either a therapeutic which can be administered outside of hospital settings, because of course having therapeutics is wonderful, but of course one of the big impacts of this disease is the enormous pressure on health systems, and particularly on intensive therapy units. So that is something, one way, but the ultimate exit would be, of course, a vaccine. This would be the real game changer, and this is also why we are continuing to intensify our efforts to, first of all, promote and accelerate the research on new vaccines, look at how we can optimize and accelerate as much as possible the authorization process without compromising, of course, the essential principles of quality, safety, and efficacy. The Commission and the European Medicines Agency have already put mechanisms in place to support the development, assessment, and authorization of new vaccines and therapeutics. The Commission is in constant contact with developers to make sure that we can, to the greatest extent possible, compress the timeline, as I said, without, of course, compromising the essential principles that would make those treatments also, in any case, not effective. So in the long term, we will need to carefully examine how to address a number of structural issues that have emerged. I mentioned, the shortages, but also how we can optimize our regulatory framework, whether we can work more in parallel on certain issues as opposed to a sequential step-by-step approach, which often takes too long. The normal time frame, for example, for the development of a vaccine is close to a decade. This is, of course, not suitable at all for a crisis or an emergency or an emerging pathogen, and that obviously needs to be addressed. We're also working on a new pharmaceutical strategy for the EU, which will also take into account the lessons learned from the pandemic, not just because there were already some clear issues even before the pandemic, issues about access and issues about availability and whether we were really getting solutions for the many unmet needs we still have. And indeed, emerging infectious diseases have been shown to be a major unmet need, and we need to see also how we can incentivize further and more research into this area. And we need also to see how we can support our health systems to increase the resilience of those health systems, and especially there are, I think, some interesting lessons when we look at how various regions across Europe responded to the crisis, maybe looking at why some countries, some regions in Europe managed to get better results. There are, I'm sure, lessons learned, and part of that might be also to the way they are structured, their health systems are designed, and that enables them to do things like, for example, community-based testing in a more efficient way, or the tracking and tracing and follow-up can be done more easily than maybe in other parts. So these are all very valuable lessons. Last but not least, the role of the various actors, our agencies, the European Centre for Disease Prevention and Control, the European Medicines Agency, the role of the Commission itself, the role of the Member States. There are certainly things which will need to be looked at there. This, of course, should not be a knee-jerk process, but it should be a well-thought-out process. We certainly cannot say we can draw a conclusive lessons learned now, because this crisis is still evolving and might still evolve in unpredictable directions. But certainly there are already some points which emerge quite clearly. So to do that, we'll of course have to very closely listen to what member states, stakeholders, experts, scientific community has to say. We're still at the start of that. In the meantime, as I said, the crisis still has to be managed. We can have a possible resurgence at any time. So this is again, but we cannot afford to wait to start to draw some conclusions and start to take some obvious steps until the whole thing is over. So events such as this one, and of course we will be trying to explore and use every possible opportunity in the coming weeks and months, will, I'm sure, help us, of course, followed by swift action to be better prepared to prevent and better manage not only possible future waves of COVID, but also future pandemics and future crises. Thank you very much.
Thank you very much, Martin. That was a very comprehensive view of the Commission actions and what we foresee. Now let me introduce you the next point of the agenda. We will have the colleagues of the European Society of Intensive Care Medicine, Professor Maurizio Cecconi and Professor Joseph Kesioglu, President-elect and the current President, and they will be introduced by Dr. Andrew Rees, the Director of Health System, Medical Products and Innovation of DG Sante. Please, Andre, it's your turn.
Thank you very much. Good afternoon, everybody. Good afternoon, Maurizio. Good afternoon, Joseph. I don't think you need special introduction to this attendees of this seminar. It's nice to have the president-elect and president of the association with us. The company's part is to really focus on the knowledge and experience and what are the gaps we can fill. So I think the best will be when we start with your experience. And this time we start from Joseph and Maurizio will continue. Over to you, Joseph.
Thank you very much. I pass the representative role to you, Maurizio. Will you share your screen?
Okay, so good afternoon, everyone. Enrique just tell me if my screen is not visible, and thank you for the opportunity. Joseph and I were going to do a double act. Just for the people who do not know us, I'm a professor of anesthesia and intensive care in Milan, in Italy. I was the front line on the first outbreak outside of China. Of COVID-19, and I'm the president-elect of the European Society of Intensive Care Medicine. Joseph Kesioglu is our president of ESIC, and he's also the head of department of the Department of Intensive Care Medicine in the Utrecht University Medical Center. So what we thought, we are going to have some slides and some discussions about the things that we've learned, and also try maybe to propose and to discuss together maybe some possible solutions. The first thing I would say is that I agree with Mr. Martin Seychelles said just now. I think one important message for all of us was the fact that I don't believe that anyone was ready for this. Certainly, when the outbreak hit Lombardy, we realized very soon a little preparation we had done for a pandemic, and that over the following weeks, that was kind of a shared experience, at least from colleagues that had a significant cluster of secondary transmission in their countries. I remember speaking with Joseph in the first days of the outbreak, that was end of February, and saying to him, look, we are seeing very sick patients coming to the hospitals, and the numbers are rising very fast, to the extent that we thought maybe other people, other colleagues around the world are not ready for this if a cluster comes to their country or to their region. And we decided together to give a voice to myself and also another couple of colleagues from Italy, Giacomo Grasselli, Antonio Pesenti, where we just wanted to share the very initial learning that we got from that. And this was our letter that went around the world. I'm sure we can do even better things than this now, but our key message was, in that very short period of time, really get ready. Get ready, because we don't think anyone is ready. And the first message I would say is that we have to talk about now is really the fact that if we were not ready once, and if we were surprised once, I completely agree with the vision of the European Commission. I don't think we can afford for our patients and our citizens to be surprised twice. I think that just would not be acceptable. We don't know how much time we have to prepare if a second wave comes, but we have to take all the time, I think, to be better prepared. Just as a very quick comment, we are intensivists, we are intensive care doctors. We can talk about the response in the hospitals and how to get ready for that. But it became very clear, I would say, pretty much in every place where we've discussed with colleagues where they had important clusters, that this is a battle that indeed you don't win just in hospital by increasing capacity. This is something that you must win, first of all, in the community with containment. And probably we have to learn, we agree with countries that maybe have done a better job with contact tracing and containment. That's very important. To believe that you can just manage this with opening ICU beds, it would just not be feasible. Then we will also talk about the challenges of opening very fast new ICU beds. Certainly, some key lessons that we believe are still valid now are the fact really to increase the surgery ICU capacity and the hospital capacity for acute patients. Again, work on the containment, we say, in the community, but also in the hospital. We find it very important to separate patient flows. If you don't do that, you run the risk to spread the disease to other patients and also to healthcare workers. That's not the right thing to do. Very important not to work in silos. To change the structure of an hospital to be ready for an emergency takes the effort of the whole hospital, from the management to doctor, nurses, and everyone, really, engineers. Train, simulate, and learn. Even if you have little time, it's amazing how much you can achieve by bringing simulation in situ. That's certainly something I did in my intensive care unit that I was trying to help in 24, 48 hours. Training people, maybe the ones that never trained, with proper protective gear to do things in an unfamiliar environment. And those hours are definitely hours that pay a lot later on in the treatment and in the care for our patients, but also in the safety for our healthcare workers. And the other key messages, which I think is two key messages that we need to keep in mind, there is patient safety and healthcare worker safety. So these two principles have to be in line there, and we need to talk about protective equipment again, and how to really protect the patients and healthcare workers from getting the disease. So this is just in short, in a couple of minutes, the experience of our learning and the experience of how surprised we were, and now we are going to discuss together possible learning points, and how we could tackle this maybe together for a second wave, or even if a second wave does not come, we have to be ready maybe for the next pandemic. I think the lesson for us was really that we have to learn and do things better as a system in every country, but maybe also would be nice to work on this at European level for the future. So, Joseph, do you want to start the discussion around this point?
We have just chosen a couple of issues which are extremely important, but they are not all the issues. We have much more to discuss outside the scope of the webinar, but I was quite satisfied as a person who did not come here only to teach, but also to learn from the Deputy Director, Mr. Seychelles' talk, that the analysis have been done very well and thoroughly. And there are some parallel issues that we have in our talk today, which are already mentioned, but we can look at it from a different angle. As you see in this slide, we have summarized the improvement points in 4, and this is actually taken from our previous contacts. You have also mentioned these things. One of them, to begin with, is the shortage of medicines. I think the previous speaker has indicated the reasons very well, but we will come back to that in a moment. The second issue in the shortages of material and equipment, and of course the number of ICU beds, but most importantly, the healthcare professionals themselves. We can have the beds and equipments, but if there are no people to take care of the patients, then we will not be progressing there. Maurizio, maybe the next slide, we can go to the shortages of medicines, and I think we can summarize the discussion points as how to manage, what we should do next time, and which medicines to prioritize, and what to do at national and European Union level. Maybe I can begin with the prioritizing of the medicines, because there is one thing very special, especially when we are talking not pandemics in general, but COVID pandemics. When we compare the COVID patients with a very severely ill ICU patients, the sort of medications that we used are not very big. The number of medicines that we use to these patients are quite limited. And this maybe is a positive issue that we can concentrate on. I don't know how it was in Italy, but we had especially sedative medicines which were in shortage. If we call the names, it's propofol and remifentanil. Okay, we have solved it by using longer-acting sedatives, which are not our preference. We had shortage of dialysis fluid because suddenly you have a lot of patients with acute kidney injury and muscle relaxants. Maybe you would like to comment there, Maurizio.
I think it's a very important point, in the sense that at least I would say for the intensive care community, the biggest problem for us on COVID-19 was not just the fact that we had a virus that we didn't know. That, of course, was something new. But very often in intensive care, we are used to fight infection, to fight sepsis, to fight respiratory failure, and sometimes we don't know what is the bug that is causing this. We treat empirically, but we do support patients with ventilators, we do support patients with different machines. Our biggest problem was indeed the volume of patients that is coming at the same time. And probably one of the key things that we've learned in intensive care is that with the right competencies and the right equipment, we can support patients and give time, precious time to patients to recover. And indeed, to do that, you need to know how to ventilate this patient, but also you need to sedate these patients properly. And the lack of sedatives, of an adequate volume of sedatives, was indeed a big problem. So, as you know, you also talk about this, Joseph. Practices like sedation holds or using short-acting drugs, that's what we prefer to do in the intensive care now. When we were finishing the stock of the kind of best drugs that we have to use, we had to move to drugs that we had in stock, but they were like long-lasting drugs and things that normally we wouldn't like to use. Funny enough, I would say in the news, people were talking a lot about new treatments. But for new treatment, we will discuss a little bit about the fact that probably so far we don't have specific cures for COVID. Well, actually, I would say at the bedside, one of the biggest challenges was having enough volume of simple, effective drugs rather than new drugs that have no proven efficacy.
And also,
but can
yes, please, Andre.
Can I ask a question in this moment? Because I think it's interesting also for us to know how, because there were, as you said, the situation was very dynamic because we also were learning about this. We were changing our clinical protocols during the knowledge arriving to you from different parts of the world, different publications. So this was one factor, but the important factor was how quick the system was able to react. For example, how long it takes to get the right medicines. It was weeks, 2 weeks, few days when you get them back to the hospital.
Well, I think it differs from one hospital to the other because each hospital has its policy. And we, not only for the medicine, but also for the equipment, we will come back, we will come there in a moment. For example, Mauricio's hospital could be different, but my hospital, for the medication, they have quite a good supply, of course, considering the last last date of use, expiring date. But our pharmacy was quite active in counting what we are doing to the patients and also extrapolating that to all the other admissions and giving us quite exact figures how many days we were still able to use a certain medicine. And they were looking everywhere to supply us. And sometimes it was working, sometimes also mentioned by Mr. Seychelles, because we were depending on countries where the first COVID hit had already destroyed the normal factory life. We were realizing that we would never get that medicine anymore. Nowadays, of course, in modern times, we have dependency to many other countries for our supplies. And sometimes we have the situation that, as we said with Mauricio, we can find alternatives. And in some cases, it's very difficult to find alternatives, like in dialyzed fluids. Okay, we still found some solutions to that, but it is really living at the edge. You don't know what you will be doing with the patient in a couple of days. This is from the medicine part. About PPTs and other protective things, I think we'll talk about it something like 5 minutes later. But it was for us very clear that the storage politic of the hospital was not adequate to go for a 2 month period with a big number of patients. That was our observation.
Yeah, I would say that probably for us, we were very surprised by the outbreak that was very fast. And some hospitals, they started to run out of the classic drug that they used. And again, sedatives were a big problem in intensive care, and they had to move to other, old style drugs like morphine or benzodiazepines, which is something that normally we don't use anymore in modern intensive care for continuous sedation. That happened very fast. But as a reflection, I was impressed by one of the things that Mr. Seychelles was saying before, which I think is a good reflection of what we've seen at European level, at least, and probably around the world. The pandemic does not move always at the same time everywhere in different cities. So some cities may be affected more than others. Clearly, every system was very scared and was trying to stockpile drugs that maybe they didn't need. So the problem with the drugs, of course, happened much more in cities and in systems that they had a very large outbreak. But maybe some other parts of the country, some other parts, maybe they had a stock that could be used. And I would say this is certainly for us, even now in preparation of the second wave in our region, is one of the reflection that we are making in terms of how do you find a way that without depriving people from the stock that they may need, maybe this could be used really where it's most needed at this time. Because for drugs like the ones that we use in intensive care, it's not that we decide to do it today and we can do it in 2 days. You really need it in the moment when you want. And just to tell you also in terms of maximization of the resources and to use the resources properly, when we can use these simple drugs that we know how to use well, probably we can cut down on ICU bed days because we can wake up patients earlier, we can mobilize them earlier and so on. So there are a lot of repercussions of this that we normally will not discuss. But again, for drugs that are related to the support of the organs for our patients, yes, we should think about how can you have the best drugs and to have an adequate amount of these drugs when they are needed in this moment.
Yeah. And again, as I said, the good thing is that they are not as variable as in a very severe ICU patients. We are not talking about 30 different drugs. Maybe, Maurizio, in the next slide, you can just give our vision a little bit about drugs, which I don't know whether, yes. I think you had another one with the, anyway, you just go on with this one. I meant the other one, especially, maybe we can say a few words about that now that I started. A lot of hospitals concentrated on magic drugs, which could be related yes, exactly, which could be related in solving the COVID-19 problem. Now, our policy as society was we should use these drugs only in the trial context and not just giving it because it might help. And at the end of the day, you saw that a lot of investments were done to some of these drugs, and as of today, there has not been any proof that these so-called magic drugs would help anyway. And maybe you would like to add the Remark study there, Maurizio.
Yes, so just to comment again on what Joseph just said, we definitely saw as a community a large effort in trying all sorts of drugs. This is not something that happened at European level. We've seen this worldwide. However, if you see how often we could actually try these drugs in an effective way, so that the research that comes out of these studies is really as internal and external validity that we use in different circumstances. That was very little. And probably after 6 months of COVID starting from China, I would say maybe we have a little bit of data on some antiviral drugs, but again, they're not magic bullets. They didn't change mortality. They decrease a little bit the time to recovery. And in terms of other drugs, we really have no clear answers. And probably a lot of the problems was the fact that we were trying so many things and not in the right way. I will try to explain this in a simple way, and then why I think efforts like Remark could be maybe something to be prepared also for the future. Because the message was we were not prepared clinically and with our infrastructures, but probably worldwide we were not prepared to do research fast and in a good way during a pandemic, even though there are some platforms for it. But the bottom line is, if I don't have a disease that has an 100% mortality, and luckily we don't have a disease with an 100% mortality, we can still save many patients. Outside of the research trials, it becomes very difficult to see if by giving a drug, I'm really modifying the disease. If I give this drug and then the patient improves or deteriorates without doing it in a controlled way, it's really impossible to find out if what you're seeing is an association or there is causality between the drug that I'm giving and the improvement or the deterioration. That's why we believe the trial data is important. Now, traditionally, and maybe this should also be a reflection for research in emergency at European level, we've noticed also as intensivists collaborating in many trials before this, that even the way you apply for internal review boards, ethics committee can vary a lot between country and country. Sometimes some of our patients, they may not be awake to consent, so different countries use different approach to get consent from families and to be able to have the patient at the right time in the study. But we think that it would be a good approach to try to give an opportunity to every patient to be in these studies. I'll give the example of Remark. Remark is an international research platform that was made exactly to study drugs and combination of drugs during a pandemic. CAP stands for community-acquired pneumonia. COVID-19, in a wide sense, is part of community-acquired pneumonia. It's a specific one, of course. But with these platforms, you can test different drugs, you can look at different effects, and you can monitor the data while it started to come. And the study is called an adaptive design study. So the information that you get from the first patient can inform you about maybe changing the design of the study and to see whether some drugs could be taken out because they are futile and there's no point of studying them anymore, or maybe study new things as well. On top of that, a big chapter probably should be around sharing information and sharing data that could be used at global level. With our society before COVID, probably our larger project for the last 18 months has been building a section and building a strategy on data science. We don't like to talk just about big data and machine learning, artificial intelligence. We really like to talk about data science more generally. And we believe that probably if we had built a larger infrastructure to share data, of course, anonymously in the right way, maybe now we would have so much data we could have analyzed and maybe identify some patterns, identify some phenotypes of patients that could be maybe targeted for different studies and for different interventions that we want to do. So basically to conclude, I would say, in terms of other treatments, what we know so far is that we don't really have a magic bullet. We still have a long way to go. And I suspect until we don't have a vaccine, if there is a second wave, we will still have to carry on to try to understand which drugs could work for this patient. And we need to be prepared better, not just for the clinical management, but also on how to do research fast and in a robust way during a pandemic.
So maybe
Your microphone.
We have to move now to that. But I feel that in this moment it is good to say that in one hand we need the research infrastructure research networks ready to go before whatever emergency starts, because as you rightly said, to set up this during emergency is very difficult. And additionally, the new regulation for the clinical trials, which still has to be implemented by all EU member states on the EU level as well, and the European Medicine Agency allowed us, these multinational, multi-center studies better. So I hope, that this will be improved, but really we have to be prepared before this one of maybe the preparedness angle we have to add to the list. So can we move now to equipment, to ventilators and others?
Sorry, colleagues. Sorry, Andre, Maurizio, and Joseph. I think your presentation is really exciting, but we should keep up with the timing. So please, if you can more or less address the next issues in the next 3-5 minutes, will be okay. Thank you.
Okay, thank you.
Maybe I can just go through quickly the shortages of material equipment. They are very similar to the medicine, but the positive thing about it is that with the material equipment, the storage time is much longer. So I think I can simply do what we should do is we should buy and we should store them so that when the time comes, we don't have the shortage of it. And especially the protective material. I mean, that was the real problem that we thought we would be going to the patients with our bare hands and without any protection. Luckily, that did not happen. The number of ICU beds, you can have a few solutions to that. The immediate measures are using the recovery beds and ORs. That's what we have done already. Building ICU bed facilities outside the hospital. There are prefabricated ICUs, extremely expensive. And what we also can introduce is the sleeping ICUs. In Utrecht, we have a central major incidence hospital already for more than 30 years, and everything is ready there, including all the equipment. And the moment something is happening, you can just open the place in a matter of hours. So it also provides you an ICU without keeping the personnel. This is one of the issues. And lastly, the healthcare professionals are very important. We have seen that the nursing personnel was absolutely in number not adequate. We told them to change their way of working from caring the patient to supervising role of other nurses. The intensivists were also, there was a shortage, but that was more acceptable. There were a lot of doctors from different specialisms who came to work in the ICU, always under the supervision of the intensivists. And we also need to have a pandemic plan. Perhaps we have it in European level. And the moving competencies is something from Mauricio's opinion, so maybe he can say one or two words on that, and then I think we are ready.
Yeah, just to comment on the thing that we just presented, Joseph, is the fact that I think very often we talked about the lack of ventilators and the lack of beds. But again, you can find a way, and especially now if we increase our stock, I suspect that will be a smaller problem now in the future because you can buy and you can create some spaces. The question is, how do we spend this time to create competencies for people to be able to use these bed spaces and this material properly? Because indeed, while it has been a very unifying moment and we work with professionals coming from many different specialties that were trying to help us, you're right, there was a supervising role of intensivists, but clearly this is not the intensive care that we are used to do normally. So it was something that we had to do to save an extra life. We were trying to use every possible resource that we have. But what we really need probably is to find a way to increase competencies of doctors and nurses to work in intensive care. And in my view, we have to think about a short-term plan, probably in the next 2-3 months, because we are not going to train intensive care doctors and intensive care nurses just in 2 months. But maybe we can do that in a few years if we take an approach that this is prompting us to increase competencies in intensive care. But for the moment, maybe we need to think about short-term courses for some skills that you can still improve in some doctors that can work under the supervision of an intensive care doctor and nurse. But maybe at the same time, rather than focusing just on moving ventilators and pumps, it's, again, this pandemic taught us that the crisis was not happening in every city at the same time. So maybe rather than creating empty spaces where you didn't have skilled personnel to work, we should think about having, I like to call it an healthcare army, but basically a way to share resources, human resources with the right skills. And I think this should happen probably at national level first, but maybe also at European level.
Okay, so thank you, Joseph. And now, Enrique, over to you.
Thank you very much, three of us, the three of you. You put many interesting questions and information. I would like, before going to the question and answer session, to invite Anne Boucher, because I saw that you raised your hand. Is that correct, Anne?
Yes, I don't want to monopolize the questions because indeed I see there are some in the chat room which are very important to answer. Now, I wanted to ask 2-3 questions as a follow-up to this presentation. I mean, one is thinking of the second wave, is your assessment that most of the hospitals have been able to replenish their stocks of ICU medicines, or that it is an effort which we need to support? And I'm asking the question because, I mean, with André, we have been working quite a lot with the producers of ICU medicines when we heard, when we were alerted on the shortage, and we have tried to organize coordination and cooperation among producers to ramp up production. And now we have identified, again, we work with the member states, so this is done centrally with the ministries of health, but we have identified 25 ICU medicines where member states think that we should increase the stocks. I mean, that is a list which we could share with you to see whether this corresponds also to your assessment. My other question is also whether during the crisis most of the hospitals have been able to increase their ICU capacity, and so they will be better equipped for the second wave, because we have the impression that, for instance, in our relationships with the suppliers and the procurers, that for instance, nobody is buying ventilators anymore. Yeah? So does that reflect a change in the clinical practice? Does that reflect the fact that the investment has been made and now all hospitals are ready? Third point is on this issue of the cross-border, the possible of exchange of medical teams, which is something which we have. But again, this is organized centrally by the member states. There are only 12 member states which had declared willingness to have the possibility of providing medical teams to another country. In practice, it has happened only twice. I don't know, for those of you who work in ICU medicine, departments, how easy it is to think you would absorb a new team, or you would be able to lend the medical staff to another country. And I have the same question on transfer of patients, which is something which has been a limited practice for the first wave, where countries like Germany have helped border countries and border regions to a limited extent. There was a demand to know whether this could be more systematic, and I think that's basically what I would like you to. If you could give us some ideas, and if you think it's better to organize the collaboration for this transfer of staff or this transfer of patients between medical staff than having a system which is centrally organized like we have. Thank you.
You want to make a begin, Mauricio?
Yes. So thank you, Anne. I would say in terms of equipment, that's my feeling, but I cannot speak for all the other hospitals in my country, for instance, but certainly I know that there are some questions that you want to ask, and we can help getting this information probably in different member states with our network of intensivists. That's also my gut feeling that now the pressure on stockpiling equipment is a little bit less. I would say personally what I see now, the biggest challenge is my country, for instance, is now seeing an increase in the number of ICU beds that we need to have ready in case of a second wave. I'm not concerned so much about building ICU beds and finding the beds and finding the equipment. My biggest concern is how do you find people to work in this bed so that actually you can really train people with the right skills, both in terms of doctors, nurses, physiotherapists, everyone. But the one the risk that you have is that you have all these empty bed spaces where you dilute your expertise because you don't have all the people to work on it. So that's why I think while the crisis has prompted some very fast action on it, and it's better to have an empty space where you put someone than not having an empty space, we really have to, I would really say that, we need to ask individual members to be ready to put people in the beds when they're needed. Going back to how you share resources and competencies, I would say country on country is probably easier, and it's something that people will be prepared because you are trained very often with similar way of working and with culturally, and the language sometimes speaking with patients and others could be a right way, an easier way to work. Certainly, I can tell you that in Lombardy, when we were under massive stress for the large number of patients that were coming to our hospitals, we would have welcomed not just getting extra ventilators, but maybe getting doctors and nurses from other parts of Italy coming in large numbers to help us. And I don't think it would have been difficult to get together to work on that. I would say that would be my first step, to ask countries to have plans on how to maximize resources during a crisis, because as we say, not every city is going to have the peaks at the same time. And I would say helping other countries should be an option, but probably shouldn't be the first option. It should be an option to escalate. If a country is in a massive crisis, go the resources there, of course we should find ways of helping and maybe moving competencies or find a way to get patients. Just one thing on moving patients, often our patients are very sick, and putting them on an airplane or transferring them from country to country is not so easy. It's a massive logistic effort. That's why I would say if I could prepare, I'd rather have skilled people that know how to work in my environment where I need when I need this extra capacity. Joseph?
Just a very short addition to that. I think it also is an important issue that some hospitals arrange things better than the others. While the problem is not of one hospital, it's the problem of the whole community. We need to have a certain of central control, distributing the scarce equipment, medicines, and protective materials to the hospitals. This could be mechanical ventilator, this could be masks. Just an anecdotal example, one of our neighbor hospitals, they were proud of having stored 80,000 masks. We said, okay, what are you going to do with that? So it was distributed centrally. And a lot of transports of the patients from one ICU to the other was arranged centrally. We didn't need to find a bed somewhere, or nobody had needed to find a bed somewhere. That's what I just wanted to add.
I would say it's a good point, and probably what saved us from collapsing was having an ICU network that was put in place immediately. And every free bed was put on the system so that you could give it to whoever was in need.
Exactly.
So thank you very much for this first exchange of questions and answers and reflections. As you can see in the screen, this is more or less the summary of the main elements that Joseph and Mauricio has been addressing. And we would like also you to put your thoughts about these questions in the chat. We will later collect all this information. And now we will go to the question and answer you have been already putting in the tabs or in the chat. So Kasia, can you put, okay, thank you. Then I will invite now Joanna Gligor, the head of unit of Open Reference Networks and eHealth, to address these questions and to moderate this discussion with the speakers and with you. So, Joanna, please. Joanna?
Do you hear me?
Yes. If you can talk a bit closer to the micro, better.
Okay, thank you very much. Do you hear me now? Is it better?
Yes, much better.
Okay, thank you very much. You have, our speakers have already provided a very comprehensive picture of the situation. And we would like to reinforce a little bit the questions that also for the audience concerning the possible concerns related to a second wave, and also related to the stockpiling. You have mentioned already some medicines, but maybe you could be a little bit more specific. Also the ICU hospital beds, what kind of preparation, what kind of better preparation should be done for the next wave. You were quite clear about the competencies that need to be reinforced, and we were wondering how could we organize this training, given that the second wave could be the preparation has to be in a very short done in a very short time frame. Then we have also several questions in the chat concerning about the risk for a second wave given the different events in Europe and mass demonstrations, etc. How do you see basically this impacting on a possible second wave? There are also questions in the chat concerning the maximum increase of the ICU capacity that would still allow providing quality for the healthcare. You have already addressed some of those questions, also speaking about the competence, but maybe you can provide additional information. How to prepare the triage, and quite a specific question concerning the role of certain medicine like aspirin in the management of COVID, also given the different discussions and different debates about this area. So we are looking at the chat. If there are additional questions, we'll raise them later, but I would invite the colleagues to the speaking concerning the cross-border transfer of the patients. If you have already provided some elements, but maybe you want to detail more. At the level of the EU, we also set up a possibility of transferring patient data cross-border, which has not been used to a large extent. What should we do? How can we prepare more for this? And there were also some other questions that you can see on the screen related to different medicines which were not necessarily given properly. So I would invite our speakers to comment.
Perhaps I can begin with the first one, which is what is the maximum increase in ICU capacity, still allowing quality, and also combine it maybe that Germany had to more than 12,000 ICU beds free. I think we have to accept the fact that, like in my ICU, if you go from 24 beds to 80 beds, you have to sacrifice a little bit from your quality. You can't exactly keep the same quality as in normal times. The only way you can do it is to have personnel completely schooled and educated for 80 beds, and then you have to keep your 56 beds empty, and which is absolutely something financially impossible. So that's what we have actually told our personnel, as I also indicated last week during my talk, that they were educated in a certain way, but considering the urgency of this problem, please don't forget that we will have to sacrifice from our quality. And every life saved is very important. This is something that we have to accept, I think. This is from me the answer of that question.
Maybe could you put the previous slide, maybe? Because you summarized some questions, but I forgot some of them.
Got them already, yeah.
No, I agree with Joseph. I think clearly we didn't have enough capacity, but the thing is that probably we didn't have enough flexibility in the capacity, because it was winter time when this happened. You can go pretty much everywhere in Europe, and wherever you go, you will find that ICU capacity probably it runs in winter for the beds that are staffed and are ready to work. Or you always run between 85 to 95%. That's my experience speaking with colleagues pretty much everywhere. What we do need in case of a very sick patient coming through is the ability to use the highest level of organ support. Some people call this level 3 organ support, so it's when you have invasive mechanical ventilation. Probably what we do need, and that was something that started well before COVID-19, the conversion to hospitals where you have more acute care and where intensive care units, intensive care department, they become a larger proportion of the ICU beds was already happening. So in some places, you're already talking about 10% of the total ICU capacity, is what you call the critical care area. In some places, it's going above that. But it's a flexible area. You cannot expect that these beds will always have somebody with an invasive mechanical ventilation device on. It could be that they are used maybe for post-surgical care, so you provide better monitoring care for this bed. So we need to build some flexibility in the system that is able to move from different levels of care without too much disruption. And the advantage of that is that you can use people that work in these common areas to be trained and to be competent and to manage a surge of what's happening. When you don't do that, and when you're always saturating 100% capacity, probably what's going to happen that You just have to get people that never worked in intensive care just to staff them. But of course, you are diluting expertise. There is a maximum number of people that a doctor or a nurse can supervise. And I agree, when you're increasing volume with people that normally don't work in this area, it's normal that skills and quality will be different. So I think we need to build resilience in the systems with probably larger critical care areas in our hospitals that have a way to deal with different patients. It could be that very often you have level 2 patients, so patients with extended monitoring, patients with only mild organ support, but gives you the flexibility to escalate it further.
Well, what we can improve is, this was the first attack that we had. What we did was, we just recruited nursing and medical personnel from other specialisms. We gave them a crash course of one single day of 8 hours, and next day they were at the bedside. But now we know exactly who these people are. So I think what we have to do is to give regular training to those people so that they maintain what they have learned, and when the second surge comes, they will be knowing what they should be doing and their responsibilities.
Yes, and indeed we can think about short-term courses to build some basic skills that can still work with the supervision of somebody expert in intensive care, but at least you have a better understanding, and you are probably also enjoying more the job if you know what's happening and how to deal with the situations.
What's the choice of another question?
Can you comment on the need of preparation of triage?
I think you had a question about the triage, and you also had you have been requested to provide more details concerning the decrease in the quality that one would be ready to accept given the circumstances.
Well, yeah.
Sorry, Joseph.
No, from my point of view, or at least from our experience, the quality that decreases is not that the patients are dying because nobody takes care of them, but you are not able to have good contact with the patient because you are completely covered. The family cannot visit. There are certain things that we normally did, like putting the patient every day on a sitting position on a chair, mobilizing them. These sort of routine things, you have to sacrifice from that. But the big picture of treating the respiration, circulation, and kidney failure, I don't think there we have done a lot of sacrifices. But these small things, maybe they are small, but they mean a lot for the patient's well-being and for the family. There we had a lot of quality decrease.
And I agree with you, and I think on the comment, the triage means different things in different countries. Triage sometimes is the way you assess patients coming to the emergency department, and that has not changed, I think, in many places. It's just that you have to separate patient flows to make sure that suspected cases and positive cases are going through completely separate flows in the hospital. That goes with containment of the infection. So that's one point, that's one thing. If people talk about triage, about patients going to intensive care, so the admission to intensive care, even before COVID, has always had to be balanced against patient wishes, patient reserve, the possibility that intensive care would benefit this patient. My feeling is that we should build capacity and competency so that we don't have to use any different assessment of what we do normally, even during a pandemic. So that's why it's important to create this extra capacity. It does not mean that everyone goes to intensive care, but anyone who benefits from intensive care should have a bed, whether we're in a pandemic or not.
Exactly. The anticoagulation question is the same as last week, Maurizio. And we also said at that time that we see a lot of thrombotic complications with these patients. And after using antithrombotic drugs, our standard measurements are not adequate, so we need to have some more sophisticated measurements. But if I remember correctly, we were both agreeing that we should not blindly fully anticoagulate the patients just because the danger is too high. We should give prophylactic anticoagulation because to standardize for full anticoagulation will also have a lot of other complications.
I completely agree. And that goes back maybe to be ready if we have a second wave to study even the role of prophylactic anticoagulation or in different ways. Regarding antiplatelets like aspirin, my knowledge is that there is no evidence that it should have a role in the management of COVID-19 patients unless patients were already on these drugs before they got the disease.
Yeah. And then the last question on the slides, are experts concerned of risk of a second wave in a week or two following? Yeah. I mean, from my point of view, the answer is yes. Hopefully, I am wrong.
From my point of view, I would say I don't know. I would say we have to be careful. But what I would also say is what was happening in Europe, at least for sure in Lombardy, but I know that it happened then also we were speaking on the phone very often, Joseph, and we knew it was happening also in London, it was happening in Paris, in Barcelona. It is obvious now that there was transmission in the community well before the last week of February. So the outbreak was already there, it's just that we didn't spot it. I think it's very important that even if the number of cases go down, until we're not over next winter, we will carry on monitoring the transmission in the community. And that's why I always say, I love to talk about intensive care because it's a job that we love and that's what we do. But the containment of the infection in the community and the monitoring of the infection spread in the community is probably the biggest intervention that you could do not to collapse the system. Because as intensive care doctors, we are providing support for patients when they're very sick, but we do not want to keep living in a society that is completely stopped just because the healthcare system are overloaded. We need to learn to live with this virus, probably. And we need to control the transmission so that we can manage the number of patients that become seriously ill from it. But at the same time, the society can restart the economy, hospitals, and probably you've seen the same. We had to stop a lot of activities that are important for our patients. There is not just COVID-19. We have a lot of high-risk surgery and other things that are important to resume. I would say, of course, we have to be worried, but the most important thing is that every country has a monitoring system in place to control transmission of the virus in the community.
Well, the question was explicitly asked on the demonstrations in the States.
Yeah.
So, I mean, if you advise everybody to keep 1.5 meters from each other and everybody just stands next to each other, holding each other, well, then I don't have a good feeling about that.
I agree.
You also have some questions in the chat concerning the specialization and using basically the doctor in specialization, and this would also bring back probably the discussion concerning the training. What would you suggest? How would you suggest to organize this training, also given the short time that we have? Online training courses, who could organize them, summer courses? How would you suggest to organize this concretely? And this is a question not only for the speakers, but also for the participants.
Okay, do you want to start, Joseph?
Yeah.
Okay, so I would say, yes, we talk a lot about competencies. I think there are two types of competencies so that we don't confuse people. One is the curriculum of competence that leads to be an intensive care specialist. And for that, several countries already have programs in place about becoming an intensive care doctor. With the European Society, we have a curriculum of these competencies that is called COBATRIS. And this curriculum usually it takes about a couple of years to get it and to go through assessment so that people can say you are familiar with all of this and you're a specialist. It's not just 2 years, it's usually 2 years and you need to have another specialty, whether it's anesthesia or another specialty to be able to become an intensive care specialist. And clearly we don't have 2 years now to train everyone that never worked in intensive care to become a specialist in intensive care, but trainees and the fellows are clearly a big resource, and in our intensive care unit, we very often work with trainees, They don't have these 2 years, but they have enough skills, and we can teach them to have enough skills to work with us, the specialists, to be able to manage critically ill patients safely. So I would say the next few months, they may be not the perfect time, but it's enough time to build up competencies under the supervision of intensive care specialists, both for doctors and nurses. And therefore, we could provide training and maybe some online training, but it's not only the online training, you need to spend the time at the bedside. So the experience that you spend at the bedside is crucial, together with the theoretical knowledge and the simulations that maybe you can do with online courses.
So thank you very much. I don't know if there is any urgent pending questions coming from the speakers, from the chat. I see that we have many questions still, but probably we will not have time to address all the questions. So we will share all the questions in the chat with our speakers, and we'll come back to you in written with an answer. So in the next days, I think that it was an incredible session. Thank you very much to all of you. I will ask Anne Boucher if she wished to say just a closing remark or a closing word on this webinar. And again, I will remind you to please to fill the survey that will appear in your screens, because that's the way we will get all your views. So over to Anne.
No, thanks. I mean, thanks for everybody to be online and have raised in questions which are interesting for us. I mean, as I said, it's been a very informative session for us. I mean, I think to some extent, I mean, Maurizio, it's good to have experts and users like you. You seem to say that we're better prepared for the next wave, which is a good sign. And I think we fully also take the message, and that's something which we really insisting on with the member states, that the monitoring and the surveillance and the testing are really the key for the containment of the outbreak. It was very good to that you share your experience and advice. We take, I mean, I think, so there might be a need for stockpiling for medicines, if I understand what you said, less so for equipment. So it's good for us to have that in mind. We haven't talked about protective equipment. Also, one of the conclusions I take from what you said is that in terms of therapeutics, we should not expect to have more in the autumn. When in fact, I mean, we hear from several companies involved in manufacturing these medicines that they expect to have completed clinical trials by September, October, and they all in contact with EMA for getting a market authorization. So I mean, there was a bit of hope that we would have more in terms of therapeutics to address a second wave. But we think also that message is quite interesting. And any information, additional information, which will come through the survey, because I mean, you're a community of people with a spread throughout the Union. So collectively, you have a very good intelligence of what is happening in Europe. And if you can share that with us, would make our actions much more targeted and much more relevant. So, I mean, I thank you very much for this session, and thanks in advance for further information and you can share with us. Thank you.
Well, thank you very much again to all of you. We will close the meeting now, and we are looking forward for your feedback. So have a very nice evening.
Okay, thank you.
Thank you. Bye-bye.
Thank you. Thank you very much.